Welcome to all of you. It's great to have your company during this One Health Poultry Hub Roadmap series. My name is Robyn Alders. I'm a Senior Consulting Fellow with the Global Health Program at Chatham House, and we're delighted to be a partner of the One Health Poultry Hub. This is the second panel in the Roadmap series, Discussions for the Future of Poultry, People and Planet, which is kindly funded by the UK government's Research and Innovation Programme. This series of fortnightly discussions seeks to address key issues underpinning sustainable development from the perspective of nutrition security and the poultry industry to contribute to the United Nations call that we build back better from the COVID-19 pandemic for the future we want. I'll just cover a few housekeeping issues before we start our presentations. Today's webinar is in the format of a 60-minute roundtable panel discussion. It's being recorded and will be available via the One Health Poultry Hub website, and the recording link will be sent to you shortly once it's available. We invite you, our audience, to please ask questions during the discussion through the Zoom Q&A function. It's now open. And as well as being able to type in your own questions, you can also upvote questions that other audience members propose using the thumbs up button on your Q&A panel. We're going to use your questions to put them to our panelists. If your question happens to be a repeat of one that's already been asked, we'll send you a message to indicate this. And if we do run out of time to answer all of your questions today, we're going to apologise, and we'd ask that you would take those discussions and continue the discussion with us on the Slack channel. It's going to be these between panel discussions that will be particularly important to the briefing notes that are going to emanate from this series. Today, our panelists are going to explore disease and health through a One Health lens. We'd also like to receive your thoughts on this topic, and to start off the discussion, we'd welcome your response to our first poll. It's open now, and it's going to be open for the next couple of minutes. We have two excellent panelists to tackle today's theme. Dr. Osman Dar is the Project Director of the Chatham One Health Program within the Chatham House Global Health Unit. And our second panelist is Professor Melissa Leach, the Director of the Institute of Development Studies. Thank you both for being willing to share your time with us. Each panelist is going to present their ideas through a 10-minute presentation. And when they get to 9 minutes, and that will let them know that they have 1 more minute to run because we want to make sure that we have time for a really robust Q&A session. So once again, welcome to you all. Welcome to our panelists, and over to you, Professor Leach. You're on mute, Melissa.
Okay, thank you very much. It's a real pleasure to be here. If I could have my next slide, which really makes the case. We're in a world where One Health, the idea of One Health, this triad of healthy animals, healthy ecosystems, healthy people, has acquired, I think, growing scientific and policy interest. And a lot of this is global and framed in some very particular ways. So I think sort of triggered and amplified by concerns with big epidemics and outbreaks, whether we're talking about Ebola in West Africa over the last few years, or indeed the current COVID-19 pandemic. There's a big interest in infectious disease outbreaks, the ways these might link to zoonotic spillover from animals to people, and the ways they unfold into crisis and emergency. Emergencies that may link epidemics with other big emergencies, the drivers of climate change and other big ecosystem changes. So the focus very often, whether we're talking about work in planetary health and the new paradigm here, or in eco-health, is very often on diseases that command global attention, often in the form of taking the form of a kind of outbreak narrative, the idea that a disease emerges often in a setting out of Africa, out of Asia, somewhere quite distant, and moves rapidly to affect the world through mobile people, mobile microbes, ultimately affecting centers of power. I think COVID-19 has quite interestingly reversed that narrative, because we're seeing the worst cases in those old industrialized centers of now Europe and America, now infecting other parts of the world. But regardless, the focus here is very much on short-term shocks, on big-scale pandemics, and very much around infectious disease and zoonoses. Well, if I could have my next slide. The work that colleagues and I at the Institute of Development Studies and through a number of different programs with partners in Africa, in Asia, have been doing has taken a slightly different perspective, asking some different questions, placing some different emphases. We've looked not just from the global, but also from the local, and asked about the dynamic drivers and outcomes of disease in different settings. That's meant asking about what actually human, animal, and ecosystem health mean in different settings, looking at local knowledges and understandings and histories and livelihoods. That means we take a different perspective on how the notion of disease is understood and prioritized. Conditions that are important may well not be those that scientists and biomedical experts are prioritizing. They might even defy scientific categories. We've been asking how it is that these interactions between people, different people, social difference, gender, ethnicity, occupation, unfold in the context of systems that are dynamic, moving up through national to global scales, and about the multiple drivers there. Critically, we've been asking about who gains and who loses, who gets sick and why. One health doesn't necessarily mean that all people are affected in the same way. And finally, we've been raising some quite tricky questions about power, asking about the politics of knowledge, who defines the problem and the solution, and whose knowledge counts. So I'm now just going to talk quickly through two quick illustrations of that kind of approach. The first comes from West Africa, the forest savanna mosaic of Sierra Leone and that tri-border region with Guinea and Liberia, where ecosystem health, human health, animal health all depend on people working and living with a highly dynamic forest savanna farmscape, in which food security, livelihood security, depending on making use of a diversity of farm, forest, swamp, and indeed hunting and fishing and small livestock keeping activities. But this is also a place where the world has focused in on Ebola. This was the ground zero of the Ebola outbreak, but also on a relatively less prioritized hemorrhagic fever, Lassa fever, transmitted by the Mastomys rodent, but also attracting its own global concern because it's seen as a potential bioweapon. And so research on Lassa has been quite intense, now coming into the frame again post-Ebola. Yet for villagers, Lassa is just one of many big fevers that they experience. It's probably less significant than other types of fever. And the One Health dynamics of Lassa are really quite interesting and raise some big questions about equity. Because what our studies in the Dynamic Drivers of Disease in Africa consortium showed was that one of the key transmission points for risk for Lassa actually takes place in women's dry season vegetable gardens, which they make in swamps in the farmscape close to their backyard gardens and kitchens. And it's the dry season where you get lots of Mastomys rodents, which is also when women are doing their gardening and weeding and watering and tending vegetables. So in effect, they become vulnerable. And indeed, that vulnerability is shown up to some degree in the caseload, which is biased by gender and biased by season. So what's the solution? You could take a One Health perspective and say, well, what we need to do is combine protecting women from this risk by integrating crop protection from rodents with disease control. And one could say it's really important to involve women gardeners in those solutions, and we've got a bit of a win-win. But I think we also need to ask other questions about whether that would actually be a priority for those women, because actually gardening has so many other values. It's critically important to women's independent income, to their ability to have income to spend on food items, source ingredients, diversity of nutrition, and other things like school fees. It's critical to gender equity. And very big questions about whether Lassa fever, as one source of many big fevers, is a priority. So one could, out of this example, propose a neat little One Health solution, but some big questions about whether that would be a local priority. If I could have my next slide. Turning to the other side of the world and to the work that our Myanmar Pig Partnership has been doing as part of the Zoonotic Diseases and Emerging Livestock Systems Programme. In Myanmar, there's a big growing One Health concern about antimicrobial resistance in the context of intensifying livestock systems, particularly for pigs here, and the fact that with commercialized systems, antibiotics are used as a prophylactic and to encourage animal fattening, yet creating risks of overuse, and therefore big demands for stewarding antibiotic supply and use more tightly. On the other hand, that very intensification and the use of drugs and commercial feed is actually viewed very positively by many farmers, because this is increasing their incomes, it's increasing their livelihoods. And these are not just large profit-making commercial farms, these are also quite local and mid-level poultry breeders. The challenges of stewardship are also made quite serious by the fact that antibiotics are not just being supplied through a very clear state or big firm-led value chain. Instead, you've got highly plural health markets, a lot of informal providers of services and drugs, a lot of self-purchasing and treatment. That's all quite hard to regulate. So what the project's been doing is to try and understand how farmers themselves are balancing these different trade-offs, how they understand potential risks in the context of livelihoods that are often very precarious and where people are balancing concerns with food security and decision-making in that context. And also balancing antimicrobial resistance with other health and economic issues. So that's required deliberation amongst health and vet policymakers, but also with people involved with wider value chain governance, looking at those concerns with AMR alongside food and health equity. Questioning industrialized food systems, but also saying we need to look at how risks play out for different people who are often producing food and raising animals in very different, diverse ways. So if I could have my final slide. These examples just raised to me, and I think my colleagues, that a One Health lens is absolutely not about zoonotic disease only, although those have been two examples that I've looked at here. But everywhere does need to be problem and solution focused. But we need to attend to what the problem is. We can't always assume it. We can't go in with a global focus and say, okay, we can see a problem happening here. We need actually to interrogate those problem framings and how they're seen by different people in different places. We need interdisciplinary work, which is, yes, bringing biomedics and veterinary medicine and together, but also bringing in those social sciences as integral, because this can actually help us bring together multiple knowledges and expertises, which have to include those more informal, those more located, often indigenous understandings. One Health, as I hope my examples have shown, always has to be intersectoral, and maybe this is the key quality. We need to look at health practitioners and the ministries and agencies that are dealing with human health, but also people dealing with veterinary health, and indeed with those disciplines and sectors that look across those: agricultural policy making, food policy making, and indeed those concerned with wider aspects of environment and planning. This means also that research and understanding needs to be engaged quite intensively with practice, with what policymakers and practitioners are doing. And finally, I think my key message would be that while globally alert, because I'm not saying that the big drivers of disease, the panics, the pandemics, the emergency responses are not important, I think we really miss some important insights if we don't connect those up with what it means to do One Health in a locally grounded and community engaged way. Thank you very much.
Thanks so much, Melissa, that you've covered some really important topics in a brief 10 minutes. Thanks so much. I know it takes a lot of work to condense it into that amount of time. We have had one question come through for you, and I'd like to ask you to answer that if you wouldn't mind. Eve Horton is asking, why does dialogue with local communities matter and how can it be achieved?
Okay. Well, that's a great question. I mean, as I hope I've already indicated in my presentation, actually, there are really lots of reasons. I think probably the first one is relevance. One Health absolutely needs to work with the real world, as it were. And it's often communities who are living in that real world, and making approaches relevant to them requires engagement. Can also often help us reframe our priorities, actually to define the problem properly in an effective way. Community engagement also brings vital expertise. It's people who are living with animals, with ecologies, and with day-to-day health issues, who have the experiential knowledge as well as to complement the formal science. And finally, I think there's key questions of equity, whether you're talking about equity from between global and local settings, or indeed equity within communities. I've been talking a little bit about gender, but there are other axes that you might want to pick out around wealth, around poverty, and so on. Absolutely require knowing and working with those dynamics, because they are very different in different places.
Thanks so much, Melissa. That was thank you for answering that question. For those of you who do have more questions for Melissa, please put them in and keep thinking about it and listening to Dr. Dar, who it's my pleasure to now ask him to give his presentation. Thank you.
So good morning, everyone, or good afternoon, or good evening, wherever you might be. So I thought I'd just build a little bit on what Melissa's been saying, and talk a little bit from the perspective of an institution like Chatham House, which of course deals with international affairs, global politics, policy, and I mean it's interesting because a lot of this does really come down to framing and whose priorities and influences is being brought to bear on both global settings, but regional and national, and then subsequently subnational settings as well. And I think it's really important that we try and interrogate some of that. So, I mean, just more broadly speaking, what do we mean by health? And the WHO has a very good definition that it's not just the absence of disease, but a complete state of physical, mental, and social well-being. And this can be expanded out to One Health as well. And so when you're looking at the interface between humans, animals, and the environment, it's not just, it's the health and well-being of the whole socio-ecological system that we're interested in. And so moving on to sort of what WHO considers the top 10 threats to global health. I think as soon as you see this list, you start seeing that that politics does play a role in all of this. And if you unpick or interrogate some of these, you start thinking, how did this come about? How was A or B or C prioritized over D, E, and F? So what do we actually mean by Ebola and other high threat pathogens? What does high threat pathogen mean, for example? A threat to who? And how is that categorization made? When you say vaccine hesitancy, are we talking about middle class urban dwelling people in suburbia in a Western European capital who think that who wrongly think that MMR is associated with neurological conditions or just don't want to give vaccines to their kids? Or are we talking about, a situation like you might have in northern Nigeria or in Pakistan, where due to a whole host of reasons, there's mistrust between the public and government, and so they're actually killing vaccine workers and healthcare workers. So whose interests are we looking at, and how is this being framed? It makes sense to have dengue there, but when you say antimicrobial resistance, for example, are we talking about actual resistance rates and deaths from resistant bacteria, or are we talking about equitable access to antibiotics in the first place, right? And are we talking about antibiotics, or are we talking more broadly about antimicrobials? And there is a difference here. So I thought I'd pick a couple of these examples, a couple of things from the list, and just talk a little bit about the politics of them and the policy, how that's developed. So starting off with the global influenza pandemic. So if you just go back the slide, it's fine. Starting with the global influenza pandemic and these high threat pathogens, I thought it'd be nice to talk a little bit about the avian flu as an example. Now, avian flu was first reported in humans in 1997. We then saw sort of very fast mutating, highly pathogenic strains of H5N1 being seen in and around Southeast Asia. So moved from Vietnam to Thailand to Indonesia to South Korea, Japan, and China. The first human case was in 2005. And the alarming thing was that, it had a high mortality rate. So for instance, in Indonesia in 2007, it was up to 80%. But broadly, between the sort of 30 to 50% mark. And what the real fear was that, it doesn't transmit as easily from human to human. But if it combines with something like swine flu, which does transmit easily, you'll then have a flu variant with high mortality and high transmissibility. And that was the big fear. But the bit I want to talk about is around what happened in Indonesia in 2007. And what happened was that the Minister of Health, Minister Supari, refused to share samples with the WHO. And why was that? What had happened was that there's a global sample sharing network, and it's been in operation for about 50 years. But what was happening was that developing countries were sharing samples. These samples were then being sent out to specific labs in the US, the UK, Australia, and Japan, and they would then develop vaccines, share those developed vaccines with pharmaceutical companies in their own countries, and then sell it back to developing countries at really high prices, often unaffordable, and often without the knowledge or consent of the countries that shared the samples. And this is what Indonesia took umbrage to, that we've shared these samples, you've given them out without consent and our knowledge, and then we're being expected to buy them back at really high unaffordable prices. And so they've refused to share the samples, and what then ensued was a big hullabaloo at WHO and across the global health system. And it was only through really tough negotiation that what was then developed was the Pandemic Influenza Preparedness Framework, which now governs how samples are shared more equitably. There are principles within there that are withdrawn from the global legal system of the Convention on Biological Diversity, the Nagoya Protocol on sharing the commercial benefits of genetic materials equitably. And there's also been an element of technology transfer, and now you've got a number of countries in the developing world which can also manufacture influenza vaccine. But that was only through, really hard struggle and, the threat of not sharing samples at all, that a low income or middle income country was able to demand its rights and get that sort of technology transfer process and system set up. It's still far from ideal, mind you, because of everything that pharmaceutical manufacturers do within that framework is voluntary. So, sharing the technology, sharing doses, it's voluntary, and it's based on peer pressure, but it's a step in the right direction. And I think that's a real lesson for developing countries, that you need to stand up for your rights, because no one's going to give them to you. The other example I want to talk about was antimicrobial resistance, if I may, very briefly. And with antimicrobial resistance, this is a really interesting one in that we were sitting in Chatham House in about 2013, and in the US, in Europe, there was this growing concern around rising rates of antibiotic resistance, and national governments were putting it on their national risk registers and seeing it as a real security threat, especially with rates of MRSA in hospitals and things like resistant E. coli infections in hospitals as well. But the case needed to be made at a global level. So one thing was, of course, to develop an evidence base around it. The other thing was to make an economic argument around this and really build momentum around that, as had been done by the Stern Review on climate change. So there's certain tactics that people understand will gain traction with funders, with donors, and across the global system. So the science came through. There was a number of Lancet series commissioned around AMR and risk factors and how to control it. What are the most effective interventions, whether it's across human, animals, or the environment? And then around the economic, political side of it, the UK government commissioned the O'Neill report, which I'm sure many of you would have heard about. It was led by Jim O'Neill, who's a famous economist who came up with the term BRICS. And the interesting thing within that was that the RAND Corporation, which isn't exactly known for its public health credentials, ran much of the report and the gathering of the science and doing the analysis around it. And it came out with figures like a lot of people would have heard about this in the media, and it's cited by lots of scientists all around the world that AMR could cause $100 trillion in damage to the global economy by 2050 and 10 million deaths. But where do those figures come from, and what do they actually mean? Firstly, I've never understood how they calculated $100 trillion or how you calculate anything to come to $100 trillion. And that was based on every infection globally being entirely antibiotic or antimicrobial resistant. So that includes all HIV infections, all TB infections, all malaria infections, and all staph antibiotic or bacterial infections as well. And how likely is that as reality? And that's what the 10 million figure was also based on. So this would be if everything was every infection globally was resistant. This is the figure that you would come to. But that doesn't really come through, in the headline figures, and you just think that, oh, okay, we're going to have 10 million deaths if we don't do anything about this. So, but the framing of that was then obviously looking at these big killer infectious diseases, TB, HIV, malaria. But when it came to actually developing the subsequent programs, those were all antibiotic or bacterial infection focused. See, so when you were making the case for the argument, all the statistics we used were around antimicrobial resistance. But when it came to developing all the interventions at the global level and providing funding from donors, it all got distilled down to antibiotic resistance and tackling that. And so there was a disconnect there in terms of the science. What happened was that we did extensive reviews of the literature, and most of the effective interventions are actually developmental issues. So it's water and sanitation interventions. It's hygiene promotion, behavior change from that end of it, and this applies across the human spectrum as well as animal health. So infection prevention control systems in animal settings or livestock settings is also really important, and those are the most effective interventions. But where did all the money go? The money all went into extensive surveillance systems, assessing and monitoring what labs are doing around the world, because of this securitized notion and this securitization of health. So not only did it distort priority setting, it also distorted how the interventions were funded and then subsequently developed and delivered. And I think that's been, a lot of the issues around why a lot of the AMR interventions are so difficult to sustain, especially in low and middle income countries, because unless you look at, as Melissa was saying, the issues at that local level, which as far as AMR go, are fundamentally framed around access to effective antibiotics or antimicrobials, the quality of those, in many of these settings, they're substandard or they're counterfeit. In some tertiary care settings, neonatal settings in Nigeria, the resistant rates are up to 75%. In Southeast Asia, artemisinin in combined therapy for malaria, some of the resistance rates are 50%. You know, these are huge numbers. We would
Osman, sorry to interrupt, Osman, but we've got lots of questions coming in for. So if you could wrap up, and then we're going to start asking you questions.
Yeah, I'll wrap up. But I mean, what I'm trying to impress is that if it was being framed by local governments, subnational level authorities, community leaders, we'd be looking at very different investments in very different areas to tackle what are ultimately global problems. And it's short-sighted of those in power to frame it in this securitized way around their own interests, because in the long term, none of their programs are then sustainable. So, I mean, I'll just move on with my other slides, but there's not a whole lot to add with these other slides. A lot of what emergence and re-emergence of disease comes down to is a whole host of factors that influence it. What I would say is that whenever you look at an intervention or a policy or program, evaluate it using the sort of bread and butter criteria of public health practice, and that is evaluated around the 3 E's and the 3 A's: the effectiveness of the intervention or policy, the efficiency in terms of cost. Are you having cost savings? The equity of it. Are you addressing the needs of the most vulnerable? Access to the intervention or the policy to those that most need it. The acceptability. Cultural acceptability, is that kind of an intervention or policy acceptable in that context or that setting? And then the appropriateness of it as well. It's not appropriate in a refugee setting, camp setting, for instance, to bring in place lots of dialysis machines where you need a whole lot of other infrastructure to run it. And then finally, the sustainability. And if you apply this to any policy or any intervention, you usually end up with the right answer. And it's when you fail to apply this kind of a framework that you get this distortion in priority setting and distortion in the types of interventions that are prioritized. And I just wanted to end with my last slide, which quotes a Scottish historian at the sort of beginning of the 19th century, so towards the end of the 19th century rather. And this is at a time when the colonial powers were convening these international sanitary conferences, which then eventually evolved into the creation of the World Health Organization. And I think, unfortunately, many global programs are still driven by these unspoken intentions. And it's funny, we've got a WHO collaborating center on mass gatherings, which has a big component on religious mass gatherings. And that used to be the real fear at the sort of the end of the 19th century, that there used to be these huge religious mass gatherings in places like India. And colonial powers, they'd be terrified that that the people they have out there running these colonies would then subsequently be getting infected with things like yellow fever and other illnesses. Cholera, of course, there were many cholera outbreaks at the time. And it would be a shame that just because, they were perhaps more vocal about it and more obvious about it because they were entrenched colonial powers, that these are the kinds of motivations that are still driving a lot of our global programs. So I think it's really important that low-income countries, middle-income countries develop strategies and methodologies to really have their own voice heard at the global level. And that might mean, having stronger regional institutions or coming together so that you are able to address these issues and stand and speak up for your own rights, because sovereignty, national sovereignty is a big issue, and just how much it's exercised is critical to speaking up for the little guy in all of this. So I'll just end with that. But
thanks very much, Osman. And I think you've made that point very clearly, the issue of equity, and that resonates also with what Melissa was saying. Just to say that I think that for those of us participating in this panel, I think there's a strong understanding of the importance of intersectoral work. Over 70% of the poll respondents chose the second option, which really focused on looking at intersectoral responses. So yes, fabulous, got those results there. Hopefully you can see those now. Osman, we've got a couple of questions that have come in that I think are very much related. Guilherme and Prof. Nitish are really wondering about what changes are needed at the global level to encourage greater One Health collaboration around disease control. And Nitish's question around working in silos and how we break them down are very related. So if you'd like to address that, that would be great.
So I think that's a great question, and I think there are structures in place. So, for instance, there's the tripartite between FAO, the Food and Agriculture Organization, the OIE, Organization for Animal Health, and the WHO, which looks to sort of advance intersectoral collaboration and cooperation. But again, within that, the environmental sector is underrepresented and doesn't have an equitable voice. And it'd be important to bring in organizations like the UN Environmental Program into that. I think at the global level, I know One Health looks at the disciplinary sciences more, and to an extent now, thanks to work of people like Melissa, the social sciences are coming into some of that too. So the perspective of communities and what they want are coming into it too. But we also need like really strong legal and trade experts within that conversation as well, and understanding how to leverage what global legal agreements are, what your rights are as a country. So there's a huge issue, for instance, around access to medical countermeasures, and within the current COVID pandemic, that's it exemplifies that. When push came to shove, high income countries were outbidding each other, doing backroom deals to get access to vaccine or ventilator equipment, and it was a free for all, frankly. And obviously, the loser in all of that is the least empowered or the poorest countries. They're back of the list when it comes to who gets access to a vaccine when it's developed. So really, having that technology transfer, having the regional capacity to develop as well as manufacture high quality vaccines and medical countermeasures, whether it's for use on the human side or the animal side, is really key and integral. And so in that respect, I would be really in favor or support the creation, for instance, of an African Medicines Agency or an Asian Medicines Agency that is able to have that regulatory function and can then bring a little bit of pressure to bear on big pharmaceutical companies. There are exemptions under the TRIPS agreement, the Trade-Related Intellectual Property System, which if as a country you declare a public health emergency, you can force the manufacture and the selling of a vaccine or medical countermeasures at reduced prices. You can go around IP protection laws. A really excellent example of that is what happened with HIV medicines, and what's happening in Malaysia at the moment with hepatitis C medicines. So hepatitis C has now become a curable disease. But the price of the drug or the course was in the US up to $70,000 for the course, $70,000 per patient, and this is being produced and manufactured by the same company that is making remdesivir, which everyone will have heard of, the drug that's being used for COVID and has been licensed. So Gilead Sciences. In Europe, the cost is in the tens of thousands of dollars, but Malaysia has used TRIPS exemptions to start developing generic versions of it, producing generic versions of it in Malaysia, which will just be a few $100s for a whole course, and that then becomes affordable. And for a drug, for a disease that affects 180 million people worldwide, in some of the lowest income countries, it's a travesty and really an injustice that they're being subjected to those kinds of prices when it's curable. So those are the kinds.
Thanks so much. Thanks, Osman. And I think in addition to answering those two questions, you've also just answered Afifa's question, which has come through, which was really around the context of equitable policy making. These are really important points, and I'd ask that people continue this discussion on Slack. It would be great if we could have some strong briefing statements coming out of that, around that point. Melissa, I see that we've got a question here from Lara Holman. And she's asking, what contributions can the social sciences make to One Health approaches?
Okay. I think they can make many, and I think what we need to aim at is a partnership that's more equitable. I mean, just as there are often hierarchies in One Health where often the medical and the public health concerns tend to trump right ahead of those with animal health, with ecological health. So we often see a set of disciplinary hierarchies where actually medical concerns sit on top, and social sciences are often drawn in just to kind of explain a few behavioral or cultural factors. And I think what we're actually seeing is the opportunity for a truly integrated approach where we have social and animal and medical and ecological scientists working together around particular problem framings. And what social science then in particular brings is both an understanding of drivers, many of which are social or political, whether you're talking about local aspects of behavior, how people do their crops, raise their livestock and so on, or whether you're talking about the legacies of conflict or political economy. I mean, social science is very much not just about local concerns, it's also about these wider perspectives, or indeed extending up to the kinds of geopolitical issues that Osman's been highlighting. And then I think the other really key contribution is to problematize knowledge and actually bring a perspective on the politics of knowledge and diverse framings into the picture. And if I might just quickly go on, I think this actually also relates to a question that's come up in the chat, I think from Khalid Mahmood, who says, how do we overcome the siloing of that often works against One Health approaches, and particularly the fact that it is often public health that dominates and we don't get people from the agri-food world sitting at the same table. I very much agree that that's a problem, and actually one might want to start instead sometimes from agri-food, and also to recognize that, of course, people, sorry about the noise, that was our fire alarm going on off in my building, that people, of course, don't live their lives in silos. And if you look at what communities are doing, and indeed what some sort of civil society organizations are arguing, approaches like agroecology or food sovereignty, these are fundamentally One Health. Human health, livelihood health, ecosystem health are part and parcel of what people are doing. And I think there's a real opportunity here to as it were, scale up that more integrated thinking nationally and globally. And I see some really positive examples in the Sustainable Development Goals, which as an integrated package actually have these different elements of health within them. In the new initiatives that the World Health Organization and WWF are doing around solutions, healthy solutions, and a new deal for people and planet, or indeed the Food Systems Summit, which is due to take place next year at the top UN level. Could we actually try and bring a One Health perspective firmly into that global scale set of discussions, complementing the integration that we already have locally, that social science and other work tells us about?
Thank you so much, Melissa. We only have about time for 2 more questions, so I'm going to ask that you both be as succinct as you can so that we can try and cover these. One is from David Simons, and it relates to equity around antimicrobials. We have touched on that in relation to vaccines. So Osman, if you could cover that topic in possibly 2 minutes. The question is, how can we respond to issues around equity for availability of antimicrobials? Scientists often focus on the reduction in the use of medications that can be used in human populations, such as colistin in animal husbandry. At the same time, large proportions of the world do not currently have access to safe, cheap, and effective simple antibiotics that can treat infections like pneumonia. Osman.
Yeah, thanks for a really great question, David. I mean, I think part of it is understanding the motivations for using antimicrobials in the first place. So within the human health sector, often it's pretty clear, but within agriculture, within the animal health sector, it's not always entirely around the health of the animal. It's I mean, the commercial implications of it are a big factor as well. And so that needs to be taken into account, firstly. And in terms of actually improving access, so my view is that national drug regulatory authorities, especially in low and middle income countries, really need to be invested in and boosted so that generic manufacture is possible, but that it's quality assured. You've got to have a mechanism where it's a viable industry as well. So, but one that's controlled. So one option is to have what they call the Netflix model, where countries or national governments commit to buying certain volumes of antibiotics, and they're the ones that then license it, they're issuing and ensure that access is available around the country. And so there isn't that profit sales volume driven model that is pervasive at the moment. So those are a couple of the things that are important in relation to that. But again, there needs to be some real reflection at the global level as well. So for use in the agriculture sector, for example, in the US, they've done a lot of voluntary work around reducing antibiotic use in the human health sector. But the Trump administration forced the Environmental Protection Agency to sanction the use of tetracyclines for citrus greening. So, hundreds of thousands of acres of citrus farms across the southeastern United States have been sprayed with tetracyclines, and there's no proven benefit that even improves the effects from citrus greening. And these are critical drugs that are used on the human health side. So their use in animals and agriculture far outweighs their use on the human health side. I'll just pause there because I tend to rattle on when it comes to AMR.
Thanks, and thanks, Osman, for mentioning plant health here. In terms of food security, plant pest and disease are huge issues. So thank you for at least bringing that into the discussion. We're going to finish with this last question, and you'll each have 5 seconds to answer a really curly question from Richard Koch. We saved a beauty for last, and let me just bring it back. Richard's asking, with current scenarios of climate change, health crises, biodiversity loss, and other disasters, I see no other immediate global action other than reducing livestock numbers, perhaps by 75%, especially intensive poultry and pigs, to give space whilst resolving human issues of overpopulation and consumption and political instabilities. This is a One Health priority. What does the panel think? So, Melissa, in 10 words or less.
Okay. Yes, but this is already happening. We badly need to challenge and move beyond the problems of our industrial food and health systems. But this can't be done as a global fix. It's got to build on the challenging alternatives which are already emerging from below in many parts of the world.
Thank you. You really did do it in 10 words or less. Lovely. Osman.
There is obviously much more to say. I mean, essentially, this is a very big debate around which there's a lot of really interesting work going on. And I think we do need to think about scenarios and alternatives, and ultimately a world that makes more space for sustainable, healthy landscapes and people and animals and plants is what we need to move towards. I would question whether approaching that through an emergency framing and a set of top-down global solutions is going to either be effective or fair or equitable, and might actually even be counterproductive. So that would be my hesitancy to elaborate in about 20 more words, but I'll stop.
So there's a couple of points
great.
that I'll make around this, and one is, and they're really important, I think. So one is, I agree that an overall reduction in total numbers is important, but more important than that, or just as important as that, I should say, is equitable redistribution of what is already being produced. So, particularly around maternal and infant child health, they don't have access to enough protein in low and middle income countries. So, nursing mothers, for instance, would benefit greatly from having increased access to poultry and meat. And you know that if there's any global initiative to try and reduce numbers, the people that will be affected most and first will be those who already don't have access or sufficient access to meat and poultry and eggs and things like that, particularly nursing mothers and infants. So I agree with it as long as you can ensure that women and children in low and middle income countries have sufficient access. The other thing is that, and this is a plug for an Al Jazeera documentary that's just come out a few days ago. I think everyone should watch it who's listening to this or interested in poultry. It's called Fault Lines, and it looks at COVID outbreaks in poultry production systems in the United States. The problem is that we're used to buying meat too cheaply. We're, especially in Europe and North America, our meat costs too little, and there are these intensified poultry systems where you've got people standing next to each other in these cold environments. I mean, the documentary was amazing because you see the working conditions, even in a advanced, the richest country in the world, the United States, and they're shocking. They're adults, usually migrant workers, wearing adult diapers because they're not given enough time to go and take a toilet break, working next to each other in a COVID-19 pandemic situation, in an environment which is cold and humid and good for virus transmission. And so you start seeing loads of outbreaks in meat processing and poultry production systems. There's no, it's not rocket science, frankly. So we have to be willing to pay more for our chicken and our meat in high income settings, while ensuring that people within our own high income settings who are poorer still have access to meat, and people in low and middle income countries who can't afford it right now also have access. So that's the real challenge within this. So I'm all for overall reductions, but you have to first get those things in place beforehand.
Thanks so much, Osman. That's a really important point. And the issue of competition between who should get access to food, sometimes if you think about pigs and poultry, they have the similar digestive system to us. So often we're competing for the same food stuff. So this is going to be a topic of another discussion in our series. So do please have an input into that one as well. This has really been a fabulous discussion. Thank you to you both. And sadly, we're approaching the end of the panel. I'd really love you to join with me in thanking our two eloquent speakers and for prompting such a great discussion. If we could just have the summary slide now so that we can just review the key points that they really wanted us to take away from this discussion. The first one being that equity and evidence are central to implementing a One Health approach. One Health approaches must also address local meanings and priorities around human and animal ecosystems. It's also really important that we understand and act effectively on complex dynamic drivers of disease, which requires deliberation amongst multiple knowledges and perspectives. And finally, that One Health is an increasingly securitized space where powerful national interests, politics, and profit play a role in determining global disease control priorities. So thank you very much. It's been just the start of a discussion. Do please move on over to the Slack channel and add your thoughts and any references you'd like to share. For those of you who have joined today, we'd really like to know what you're going to take away from this discussion. So do please complete the poll. It's just popped up there now. We'd really love to know whether you've taken anything new and insightful away from this discussion. So finally, we're really getting close to coming up to the hour now. So thanks again to the panelists. Thanks to you in the audience. Thanks to all the support people who have helped this all to run so smoothly. We really hope that you'll join with us for the next panel session. If we could have that slide. It's going to be on the 11th of November at the same time. It's going to be looking at pandemics, past, present, and future. And it's going to ask 3 questions. How and why pandemics have shaped history? What will the legacy of COVID-19 be? And how can risk mitigation prevent future upheavals? Our 2 panelists will be Professor Stuart Reid, the head of the Royal Veterinary College, and Miss Heather Quinlan, an author out of the US who has just released a very timely book on plagues, pandemics, and viruses. Thanks so much for your time and do take good care. Bye-bye.
All right.